Good morning, ladies and gentlemen. It's a great pleasure to start this last day of the EAO Congress 2025.
It's 9 now.
It's 9 now, right? I started too early.
It's good. So, dear colleagues, dear friends, good morning. It's really, I hope that you are in a good shape after the wonderful party, white party of yesterday. And thank you to be here for a Saturday morning after 2 days of exciting scientific program. So, on behalf of the EAO and SFPIO Scientific Committee, I would like with Luca to welcome you to this session titled Timing of Complication Management Bone Grafting Procedures. I would like to thank warmly our 3 speakers because talking about complications is much more difficult than to talk about our successes. So, Luca, can you talk to us? Can you tell us more about the program?
It's true. You said that perfectly, that talking about complication, it's a hard thing because we are really used and we love what is working in our offices. But we must understand that the complication is part of the game. And we are going to see this, how to not just manage the complication, but particularly for some scenarios, how to avoid the complication or to limit the risk of complication in the scenario of a post-extraction site treatment with immediate implant placement on the bone augmentation scenario, so when we are going to reconstruct the bone to place the implant, and in the perimplantitis, meaning what we may face on the long term after the surgical treatment of our patient. And Hadi, I have a question. Do you have any complication in your clinic?
Complications, me? Oh, never.
Really?
Oh, yeah.
I mean, when you say this, or you are a very lucky man or you're a liar. So
what about you?
I have.
Oh, good.
But it's really, we must understand that we don't have to feel guilty if we have complication in our offices. And sharing the negative experience may help each other to find better solution. So, let's go.
Conclusion, if you don't have complications, whether you're lying or you don't do
any surgery.
It is our pleasure now to introduce Romain Dolivreux, a young and talented oral surgeon. He has, he has a private practice in Mulhouse, close to the Swiss border, and also he has a practice in Germany. Mm-hmm. He has a Master of Science in Oral Implantology and Implantology, and he has spent 6 years in the Fourrure Clinic in Germany. The floor is yours.
Thank you very much. Thank you, guys.
Enjoy.
Thank you, Peria, for your great presentation. I'm extremely happy to be here and to share this moment with you. I'm so thankful to have the chance to present you this presentation. And my topic is complication management during bone augmentation procedure. So the normal way of a presentation, the speaker is going to start, the clicker is not functioning. The speaker is going to start with, and the presentation is not running, maybe you could help. So the speaker is going to start, first of all, probably with a success, showing you a success story. So you have a vertical defect. I'm going to show you the photo in a few minutes. And then you have to rebuild the defect. And most of the time, the literature and the speaker are speaking for sure about success. But sometimes, happens, right? So we have to deal with that. And I had a view on the literature, what is happening on the complication scene. And you have not too much literature, unfortunately. Thank you very much. Not too much literature. So success, I go very quickly on this success. Success story with the bone graft. Vertical bone graft is autogenous bone. After 3 months, you can place the implants. Best surgeon of the world. And this is good. But complication is part, and you told it, Luca, is part of our job. There are many techniques. Each of us have a different techniques, and complications are belonging to all techniques. They are not a perfect technique, unfortunately. Complication prevalence rate, how many complications do we have? According to techniques, it's very different. We have not too much literature, unfortunately, and the range of complication is going from 0%, lucky guys, to 78%, unlucky guys, right? And then regarding to the techniques you're using GBR, they are showing 10% complication with exposure and some infection, hip bone 26%, and so on. And the big problem of all this literature, they are speaking about sometimes different types of complications. So to compare different technique, it was a tough work for me to put this presentation together because literature is missing a little bit on that topic for all kind of bony-rich augmentation, sorry. So let's make together for our work today, small definition. What is for us this morning a complication? The most common one is for sure dehiscence. We have dehiscences with bone blocks, with membranes, with a titanium mesh sometimes, and this is not the worst complication, but we have to deal with that one for sure, the most common one. Then we can have anatomical complication during the bone augmentation procedure. The major problem will be the alveolar nerve for sure. The worst in my mind, and I guess in your mind too, is infection. Infection is a real issue for us. We're working in a septic environment in the mouth of our patient. And resorption is also belonging in my mind to complication, because if you're reopening your site and you have here on the palatal a resorption, maybe the bone block was not stable enough, I get it was a problem, then you can put your implant on the proper way. And the last one, and it's my favorite one, we are all good surgeons building beautiful bone, but sometimes the healing is quite good, but it's not done according to the prosthetical plan. And we have an issue to place the implant. Everything is well done, but the bone is not at the right place. I won't speak about sinus lift. It's also a ridge augmentation, but it will be too long to cover all these areas. So we will focus on ridge augmentation with a membrane, with titanium mesh, and with bone blocks. Dehiscences. I will speak for each kind of complication about how can we prevent them and how can we treat them. The prevention of dehiscences is quite easy. It's well described in literature. You have to have a closure flap without any tension. The incision for sure is very important. You published a nice paper, Luca, on that one. So you have to release the periosteum to be able to close the flap. This is nothing new, but to have a flap closure without any tension above the graft. You can use a lingual flap, you can use a buccal flap, and also very important is the suture to have a tension-free suture on the top of it. Soft tissue, for sure, if you have a good soft tissue and you have the chance to extract the tissue, you can bring some more keratinized tissue, just like in that case, but this is not mandatory to prevent a complication. It's a plus, it's not a must. And temporization. Temporization is a big issue. If you have pressure on the flap just after the bone graft, then you may have an opening of your flap above your graft and then contamination and so on. So removable prosthesis is in our office at least not existing anymore, for full arch at least. And when we have to deal with a full arch, we are placing provisional implants. We have planned everything before we're able to print a temporary bridge. So this is a resin printed bridge. And we are protecting the graft with this temporary bridge fixed on the implant, and everything can heal under the temporary bridge quite easily. And we remove them for sure at the end of the procedure during the soft tissue management. The treatment of the dehiscences is quite easy, and it's quite the same for all techniques we have described already. So if we remove one implant, we have wait 2 months and we go for bone harvesting in the retromolar region. We splitted the bone block in two, exactly the Curie techniques on its original methods, and we make one block on the top, a second block on the lateral part. We filled everything with particulated bone. We close the flap without any tension, thanks to this lateral approach, well described also in his book. And then we wait the healing. And unfortunately, after 3 weeks, something like that. For sure, this is not nice, and you're getting nervous when you see something like this, and it was probably my failure because the bone block was placed too much on the lingual aspect, and I had a perforation of the flap. What to do? For all techniques that describe the same, you have to eliminate the exposed membrane, the exposed block, the exposed titanium mesh. So with a bone block, it's easy. You use a diamond burr, and you make local decontamination to avoid an infection with chlorhexidine, gel, and mouth-rinsing solution. After 6 weeks, if you're lucky, you will have a granulation on the top of your bone graft. For sure, using autogenous bone might be maybe an advantage here, and you can go further in your implantation, and you can see after 3 months, after the healing of the site, we're able to place 3 implants in the correct position. We made a relining just to stabilize a little bit the volume. It's, in my eyes here, it's more about the volume because we've lost a little bit with this exposure, and we could have a nice and stable success in the time here with this vertical bone grafting procedure after 4 years. I like also this classification of San Sanchez because it's joining the world of infection with the world of exposure. So you have class 1, class 2 exposure without any infection. Class 3 is an infection without exposure. And then class 4 and 5, infection with exposure. And you see, at the moment you have an infection, you will get the risk of graft loss, completely loss or partial loss, which is an issue. An infection is always a nightmare when you saw a fistula or some pus on the top of the gingiva by a control. You're always getting nervous for sure because this is really an issue. The bacteria are more quicker than the revascularization, and you can lose partial or totally of your graft. And when you see that, please don't wait, because if you wait, just in that case, for removing contaminated biomaterial, for example, also contaminated autogenous bone, you will have huge defects, which are extremely difficult to rebuild from the hard tissue and from the soft tissue point of view, and achieve results which are okay, but really not perfect. So you have to deal quickly with infection. I think this is a key message, maybe. And to prevent them, nothing new, you have to pay attention to the neighboring teeth, to the period health of your patient, to work in good condition and to avoid any bacteria from anywhere. And the treatment of infection, I just do one case of mine. I didn't pay attention. This patient had in the upper removable prosthesis, and I didn't know it, and she wear it, and it touched the vertical augmentation in the lower. So after 2-3 weeks, I had this fistula. You try to drain. First reflex, we try to drain the infection. So we make an incision. You see the pus coming out nicely from your bone block. You start to cry for sure at the beginning. And then you see what is moving, what not. And when it's early, it's difficult. And here I had to remove everything. I've lost everything, but I didn't let the contaminated material inside. Recommendation in this paper from Urban, he has 2 classifications, class 1 low grade, class 2 high grade, and you see if it's early, you have a big risk to lose everything. He tried in his work to keep something with antibiotics, systemic antibiotics, and to remove the material after 5 weeks. In my humble practice, we tried to just open, to rinse, and what is infected will be removed. So it's bad. Infection is really the worst thing you can get. Resorption, our next chapter, to prevent resorption. This is a very long story, so we could speak all the day about resorption, I would say. In this meta-analysis of Professor Hamel's group, you have 8 recipient site, mandible, and maxilla different. Soft tissue pressure is a very important factor, and the bony envelope, when you're coming outside the bony envelope, you have for sure more resorption. But what I love and what take all my attention is this sentence: the resorptive pattern tend to follow the original anatomy of the ridge. And this is logical. If you have something functional in the muscle corridor, the muscle will tend to work around your graft and not to press on your graft. And that's why we are treating our patient in this manner nowadays. Here's a full arch rehabilitation. The girl has no teeth since 20 years. So first of all, we are going to do a smile design just to try to give her a new smile. And we are analyzing how she is chewing. lateral protrusion, and so on, and we are recording everything with the total prosthesia in order to try to correct or to keep this function and the teeth positions. Then my lab Leo is going to put those two elements together, the wax up and the aesthetic part with the smile design, in a functional wax up. He's spending a lot of time in this wax up and checking everything. Then we go for surgery. First step, we have to put a fixed temporary restoration on 4 provisional implants, 3D printed. We wait 2 weeks and we can go for the surgery. It looks like that when you open the flap. And if you have no plan, you will try to augment everywhere. Is that a good idea? I'm not sure. And that's why to have a prosthetic plan and to try to follow this muscle corridor and to stay in this muscle corridor, then you will just maybe be a little bit less invasive with your augmentation. And you will augment sometimes more on the palate, sometimes on the buccal aspect, just following the wax up. Same on the other side. I'm going a little bit quickly. This is all autogenous bone with 2 harvested sides, and we wait 3 months under this region. You see, after 3 months, the remodeling of the buccal aspect of the bone is almost zero. So the muscles, it was a nice new envelope for this muscle corridor, and we could place the implant in the correct position. And this is stable over the years. This is only autogenous bone without any biomaterials, but this is stable over the years. So I don't have too much experience. This is only 2 years, but it is a nice result for 2 years. So I would say for resorption, for prosthodontics, it's extremely important to have a plan, the prosthetic and plan. My friend Weil, he's always saying, the bone gives the tone, soft tissue is the issue, but the pros is the boss, and that's right. Also, I guess in 225 for bone augmentation, we have to follow the wax up. The wax up is the key. Anatomy is the last chapter, and this can provoke bad complications. During the periosteum incision, here you have the mental nerve, and just under the periosteum, sometimes very superficial, as far as you go on the lip region, you can have the ramification of the nerve, and you have to pay attention. And also for bone harvesting procedure, using a 3-fine burr or using a bone block, here with a bone block, you can have nerve exposure, which is not bad at all, but you can, and you have a nice paper of Professor Curry on that, but you can also have damage of the nerve, and then you have paresthesia, dysesthesia, and so on, which are quite seldom. Luca, he published this paper on guided bone block harvesting, which is great because you can prevent everything. You can design your bone block exactly as you want, and you're not harvesting too much, you're not harvesting too less, you're not harvesting in a dangerous area. So this is a super idea. And you can also harvest a bone block with navigation. The small disadvantage of a guide, in my eyes, it's you have to open a flap which is a little bit wider. This is the only problem. The advantage of navigation is that you can plan everything. I'm going to show you this last case. This lady has a front, in the front region, periimplantitis. We have to remove the implant and the neighboring teeth. We do soft tissue closure every time with soft tissue punch. This is only soft tissue, no bone material inside. We wait 2 weeks, and we're starting with the planning. You see the defect. We make a smile design. We put the smile design on our planning software, Codiagnostics. We can place the implant not in the bone, but accordingly to the wax up. Then we can rebuild the bone according to the implant position. So we go a retrograde treatment plan of the bone graft. And then we can design 2 guides in order to hold those bone blocks. And much more interesting, we can transfer those bone blocks on the retromolar region in order to try to harvest exactly what we need. Then we transfer this STL data to the Navident software, which is a navigation system, and we can plan your osteotomies exactly on what you shaped before on your 3D planification software. You can see where is the nerve and so on, and then you will use this planification during a surgery. You have a piezo device mounted of this navigation software, and you can see during the surgery what is happening with my saw. Am I far away from the nerve? Am I far away from the root? And it can be a great help at the beginning for a bone harvesting procedure. Then you are luxating the block on the normal way, nothing new, and we will split it in two according to the Curie technique. What is really cool is that you harvest just what you need, not more, not less. So you have very less more bite, and you have no chance to injure the nerve during your procedure normally. We split the block, we scrape it, Curie technique, and we put the block in this guide. We put the guide in the mouth of the patient. We just have to stabilize everything with some screws. You remove the guide. I'm going a little bit quickly because I'm out of time. We put the second guide for the palatal block to make our vertical augmentation. You see here those stainless steel micro screws. And then we fill the gap with only autogenous bone. We close the flap without any tension, releasing the periosteum. And we wait 3 months. After 3 months, you can plant the implant with a cesty stem, place the implant accordingly to what you planned, and you see the quality of this bone without too much remodeling. I was lucky on the buccal aspect, placing 2 reduced diameter implants just like you prepare here. So this is the case. After 8 months, the prosthodontist could make the definitive restoration, and he after 2 years. And this technique, we published it with my brother and the JOMI. Very quickly, to prevent issues, think anew, soft tissue preparation, mouth cells of your patient for the infection and appropriating premedication, and have a plan to be able to prevent the anatomical risk, resorption, and prosthodontics. And the treatment of your complication. Dehiscences have to be for sure prevented with a local, to be treated with a local removal of what's exposed, decontamination, and you've heard anything. I would recommend also, I'm sorry I'm late, ACC classification from the ITI, and thank you very much for your attention.
Thank you, Romain. Thank you very much for such a beautiful presentation and a lot of interesting points that will come later on the discussion for sure. And now we're going to introduce Professor Mario Roccuzzo. Welcome.
Thank you. Welcome.
Adjunct professor of the University of Turin, a worldwide well-renowned periodontist, member of the IAO, and active member of the Italian Society of Periodontology. Just one note before.
Yes, please, you can ask your questions on the application. So we'll have, at the end of the session, 20 minutes of discussion.
Thank you. Mario, the stage is yours.
Thank you. Good morning. Good morning. Okay. Thank you very much for being here this time of the day with so many things going on at the same time in other rooms. I'm so happy to be here. I would like to thank the organizing committee for giving me the opportunity to be here. And we'll talk today about only the reconstructive periimplantitis treatment and the complications. But the first question is, does it work? Because if a patient of ours goes on ChatGPT and asks, does it work? The answer he gets or she gets is not really nice. The strategies are unpredictable, do not seem predictable. No predictable regenerative protocol has emerged without a predictable treatment. So apparently, in the literature, there is no much common remedy for the predictable treatment of periimplantitis disease. And part of it is probably because we are talking about treatment of periimplantitis as if all the implants were equals. But there is a huge difference between one implant and the other one. So maybe we should think about the treatment or a specific implant or a specific surface. And since there are many protocols published in the literature, I will just spend a few minutes talking about mine, just because it's the one I know best. But maybe other protocols will work better for other types of implants. And the idea is to remove the granulation tissue, to decontaminate the surface of the implant with EDTA chlorhexidine gel, and to reconstruct with the protonized bovine bone mineral with 10% collagen. And this is the result of several trying with different materials. Now, one thing which is, I think, is very, very important is that periimplantitis starts from the soft tissue. So if I don't have keratinized tissue around the collar of the implant, and we have lost probably the periosteum because of the inflammation, I use a connective tissue graft to cover the graft and to protect the graft and to create a soft tissue collar around the implant. I think this is very, very important. It's mandatory. And the importance of a keratinized tissue was also confirmed in one of the EFP consensus conferences in Segovia a few years ago. Now, another important aspect is the flap design. If we talk about perio, many authors have described in details how you should perform your flap. You preserve the papilla, you do an incision like this, you make sure the papilla is simplified. Somebody comes and said, oh, no, I want a simple flap procedure. So there is a huge literature in the present regarding the best way to do regenerative treatment around teeth. What about implants? Nothing is said. Full thickness access flap, full thickness mucoperiosteal flap, full thickness flap were raised. I mean, open a flap on the buccal, open a flap on the lingual, put something inside, close. This is not regeneration. This is not regeneration. You're just adding something to an access flap. So maybe this is the reason why we don't have enough evidence on the quality of reconstructive surgery for periimplantitis defect. So if I have a case like this, when there is no keratinized tissue, and I want to make sure that I will close the flap on top of my regenerative material, I make a single incision and I keep the papilla so that I have a recipient site for my flap later on. And, very, very, very important, I keep in mind the reconstructive treatment is much more than adding a graft to an access flap. Even though in our last randomized controlled clinical trial we see in the literature, they open up the envelope for randomization after they open up the flap. Because for the clinicians is one story, for the statistician is another story. So we have two different views. So you see the connective tissue graft, which is rounded. It's punched at 4 millimeters, so it can be well adapted around a 4 millimeter implant. It's positioned in this way, suture, pre-op, post-op, and if everything is well done, if you're lucky and the patient is under control, you can very often keep the implant for many years. So my suggestion is to limit flap elevation and to avoid vertical incision as much as possible, just like we do in perio. And of course, a proper decontamination of the implant is very, very important. I personally like very much this electrolytic way to do it, but maybe we don't have enough evidence to prove one thing is better than the other one. And how deep is the defect is the least important factor, just like in perio. The deeper is the defect, the higher are the chances to do a nice, big, fantastic regeneration, which is very important, once again, is to create a soft tissue seal around the collar of the implant. So, if I'm forced, because the defect is very deep, to open up a flap lingually and buccally, my connective tissue graft will be 360 degrees around the collar of the implant. So then I can protect and seal the collar of the implant. How many papers about this have we seen in the literature? None. So dear friends, I'm forced to give you not evidence-based, but personal opinion, which I know it's not nice, but that's the only thing I can do. And again, if you do things properly, even if the defect is almost to the apex, even if the defect is very, very deep, you can obtain good results in a high percentage of cases. Pre-op, post-op. Now, do not try reconstructive surgery around implants which are poorly placed or poorly restored. Because again, if you look at the literature, you see some papers, you see some pictures of the papers, and you see that many of these implants are not well positioned, are affected by periimplantitis, maybe because they were not properly placed. And these are papers which are published recently. Why is that? Because if you are in a university department and you want to publish an RCT, you collect as many cases as possible, and the number of cases you collect for the statistician is much more important than the quality of surgery you perform. That's a reality. You see these implants, maybe we can do something to treat these patients, maybe we can help them, maybe we can keep the implants, but I don't think it's proper to collect the data and make a meta-analysis and report, quote, evidence-based, so that we give wrong indication to the clinicians just because the cases were not properly selected. Now, a question I receive a lot about membranes is, as you can see here, there is a membrane treated here. I used to treat these cases with membranes. I don't do that anymore. Why? Well, there is enough evidence regarding that. Few studies suggest that the use of a barrier might increase the rate of early complications. The addition of a barrier membrane does not seem to enhance outcomes. The study failed to demonstrate the presence of an added benefits using membrane. While membranes are currently used, current evidence does not justify the routine use. Comparative studies failed to identify clinical benefits of the adjunctive use of a barrier membrane. So there is enough people around the world that really don't like to use membranes. I have been using membranes. This is a case. But the adaptation of a membrane is very, very difficult, particularly if you have a severe defect, because you cannot seal the flap on top of the membrane. And that's probably the reason why we have oftentimes exposure of the membrane and subsequent infection. Regarding timing, which is the title of our presentation, when should we start reconstructive periimplantitis treatment? Well, it depends on the circumstances. In a case like this, you have a defect. Maybe you can treat the defect with a reconstructive approach. But this is not the right time, because we have a patient with many problems, including the periimplantitis. So we first have to look at the patient as a whole, and we have to make sure he is under control, which means plaque control under ideal conditions. Typically, we set up a cutoff at full mouth plaque score at 20%, full mouth bleeding score at 20%. And then, after that, after you are sure that the patient is under control, you treat the periimplantitis defect. The opposite mistake, trying to treat severe cases with a non-surgical approach. I've done that mistake myself. This is a case with, in 2009. You see the probing with the probe, which is almost 9 millimeters. And the patient was kind of reluctant to go for surgery. So I encouraged him to do it, but he didn't want it, so we kind of lost time. We did, in the meantime, treat him with local antibiotics, scalar root planing, but after a year, it's worse. So if the defect is severe, do not spend time with non-surgical approach, because the chances you're going to be successful is very, very low. While if you go for a surgical approach, even if the defect is deep, almost to the apex, you can be successful, you can obtain good results. And basically, we have seen that the classification, the defect size and defect morphology is not as important as we have thought in the past, as other authors have explained. One thing which is very, very important is how the patient behave. We have seen after 5 years that if the patient was good in maintenance, namely good plaque control, the chances of losing an implant which was treated according to the protocol was less than 10%. If the same patients, the same group of patients, during 5 years did not perform well in plaque control, almost 40% of those implants were lost. So that's one more reason not to start treatment of periimplantitis with a reconstructive approach if the patient is not under control. First, look at the patient, then look at the X-ray of the defect you're going to treat. Now, even if you do things properly, is it true that it always works? Absolutely not. Nothing works always forever and ever. Let's see a case, for example. This is a case I treated in 2007. Then I sent him to the colleague for the prosthetic treatment. In 2010, he was sent back to me because you see there is a deep pocket. Okay, I said, so let's go for for reconstructive treatment. I mean, the patient was in good health. He was under plaque control, so everything seemed okay. Then after the local anesthesia, I realized that the dentist had placed a ceramic crown with provisional cementation. So I was kind of in a sad situation. So I decided to cement during surgery, clean everything, and suture, which we did. And apparently things went well. That's 2011. After 2 years, he comes back, and there is a huge defect with pus. What to do? Well, it's important we discuss this with the patient. If the patient is willing to go for a second surgery, we go for a second surgery. Not often, but sometimes it happens. We go for 2 surgeries, which we did to the best of our capabilities. Everything seemed okay for a while, and then a fistula. We tried to clean properly. We use photodynamic therapy. We really worked a lot with the patient, and indeed, we were able to keep the implant for many years, and the patient is still under control. In this specific case, 3 procedures were necessary. So sometimes things don't work at first. Then we always have to talk to the patient, because we have here a patient who is happy even though she has periimplantitis. And we have to convince her to go for surgery because she didn't care. She was happy. And I said, well, you have a problem, you have bleeding, you have a pocket. Okay, let's do it. So we go for surgery, step by step, and then we have a recession. And now she's unhappy. The site is healthy, but she's unhappy. So we have to treat her according to the principle of connective tissue graft. My preference in these recessions, which are not too shallow, is not to do vertical incision, is to make a split thickness flap envelope, take a graft from the tuberosity, U-shape, adapt it to the color of the implant, suture, and if the defect is not too deep and the implant is not poorly placed, we can obtain good results. But complications do occur, particularly in periodontally compromised patients. This is a story of a lady who started with me in 2003 for an implant placement, for a premolar. Everything seemed well, was like an easy case to treat. At first, I was even happy because look at the recession of the natural tooth, but the papilla mesial to the implant improved, so I was very proud of it. But then, a few years afterwards, she gets a defect, and we have to treat her periodontally for the treatment of the defect around the molar, the first molar and the second molar, which we did. And she was put under a severe supportive periodontal care program, which meant she came about 3-4 times a year. And she was doing very, very well, and we were very, very happy with that. But then, after a few years, 5 years in this specific case, we have a complication. And it's hard to tell if it's periodontitis or periimplantitis. Nevertheless, we have to treat her. Yes, there is a complication. And I cannot blame the patient, I cannot blame anyone, but the problem is that she is a patient with a history of periodontitis. So she is at risk. at higher risk, no matter how hard we try. So we treat the defect, and again, it's perio, an implant, but we apply the principle of surgery which we've learned in perio, which is try to avoid vertical incision, try to be minimally invasive, protect the graft, support the flap, early healing, and once again, we have a patient who is upset because aesthetics is not really great. We have a recession. Every time we treat a periimplantitis, every time we treat a severe defect of periimplantitis, we have to keep in mind the risk of recessions. And this is what must be discussed with the patient before that. So in case like this, once again, I'll show you what to do. My suggestion is to avoid vertical incision, make an envelope flap, split thickness, mesial distal to the defect. I typically use a 12B blade, and I try to avoid the elevation of the lingual flap, and I try to avoid the elevation of a vertical incision. So we use small instruments, just like we have learned in perio. We use a small elevator. We can even use a probe to make sure we don't tear the suture. And we take the graft from the tuberosity, which is thicker, denser. We U-shape it, and we adapt it around the core of the implant. Most of the time, we don't even need to fix it to the core of the implant because the flap will be pressing the connective tissue around the core of the implant, so it will stay there. The suture is a modified vertical matrix suture so that we can really adapt closely the flap around the core of the implant. A few more seconds, Mr. Chairman, and I'm done. Here we go. And if you are lucky and everything goes well, we can be happy with that. But we know that sooner or later she may have another complication somewhere else because she's a patient with a history of periodontitis. So, my personal take-home message is periimplantitis defects around properly placed proper implants can be successfully treated by proper reconstructive surgery in a high percentage of cases. And I know there are many proper things, and that's the message, because you cannot treat things just like that. It has to be proper treatment around proper implants. In that case, you can be successful in a high percentage of cases. How to do it? How to reduce the risk of complication? Don't start if the patient is not clean, is not under control. Use a minimally invasive surgical technique. Select carefully the grafting material. In these circumstances, we never use the name of the product, but there are many products around, in the booth upstairs, but not all of them perform as well. Select carefully what you use. Create a soft tissue seal around the core of the implant, and check the patient carefully and frequently. And with this, I thank you very much for your kind attention.
Thank you. Thank you, Mario, for amazing presentation. Thank you all for really great lectures. Obviously, we had some questions. We have some questions from the audience too. And I will start first from Mario, just because he finished the lecture. And when you were talking about the deep defect, that is for you a cutoff between non-surgical or surgical therapy, which is your personal number? Because so that we can share a number.
I don't have a number, but we have enough evidence to know that if the defect is deep, and probably I would say after 6, 7, the non-surgical therapy is not effective. Also, is also important the position of the implant in the crest, because if you do surgical procedure, you can create extra tissue, you can create more volume buccally, while if you have a non-surgical approach, you have to be content with what you have. On the other side, I've seen also people speaking about non-surgical therapy, but they do anesthesia. They are very aggressive, so we have to be careful about what's surgical and not surgical. Surgical means what? I mean, if you do a non-surgical approach, but you do local anesthesia, and you are very aggressive, to me that's surgical, even though it doesn't mean you do sutures.
Okay, perfect.
But you cannot decontaminate in these cases.
Well, they claim, people who love to show non-surgical approach, they claim they can still decontaminate with air powder and other chemical methods. So the problem in this topic is that remember, a few years ago, perimplantitis did not exist. Everyone was coming to the podium presenting 99.8%, 97.9%. So it's a recent field. So I think there is lots of research to be done. Knowing that only the implants are very much different. So we talk about implants as they were the only thing, but the contamination of one implant is much more difficult than the other one.
Yeah, and regarding because we saw fantastic cases where were stabilized, but after several surgeries, meaning that there was a recurrence on the pathology. Just an extremely practical question regarding the cost, because I was quite curious if the patient is going to have all the cost every time, or there is one point where the treatment is...
No, my patients pay the cost of the time. I have a policy in my office. If they come regularly and they do what I say, and they lose their implant within the first 10 years, they get the implant for free. That's an encouragement to come regularly and to attend my office as requested. And it happens maybe once, twice a year. I place 1-2 implants per year for free because they were under the protocol 10 years doing everything I said.
Yeah, thank you.
Pooya, maybe
yes, please.
We're talking about complication today, and you talked about antibiotics, prophylactic antibiotics.
Yes.
What about with acute infection, giving the antibiotics 48 hours before? Some authors talked about it. So what's your opinion? What's your experience?
Thank you very much, Hadi, for your question. It's not in all the cases possible. You have to analyze the case when the patient has high demand or high smile line, and you have difficulties like thin tissue, thin bone, and an infection, then you should let it. Yeah? But when you have easy cases like me, when I'm smiling, you cannot see my gum. Yeah? I have recessions everywhere, but don't care. Yeah. Mario is sitting here, Professor Zucchelli is there, can ask them. This is something what you have to analyze. You analyze the person, you analyze the case, you analyze the socket, and then when you see you're more on the safe side, you can prescribe an antibiotics maybe 2 days earlier when you have enough bone, enough soft tissue, everything is good. And also after giving the antibiotics, the infection will disappear. It's a good sign. But we had a discussion with Luca yesterday. When you have an acute infection on teeth, you don't start giving the patient with any symptoms antibiotics. You open the derm rage, the abscess, and then you look for the pre-symptomatics, all the signs what we have to check, and then you prescribe antibiotics. It means this is from case to case different. Thank you for your question. Analyze the case, the whole case, and then you can decide.
I have a question also for Pooya, and which is your decision tree to graft the soft tissue in the post-extraction site? Is something that is anatomical related, or is the pressure given by the patient in terms of final result?
Nice questions. Thank you, Luca. You know, we had just 18 minutes. I skipped few of the factors due to the time. The evidence on soft tissue grafting by immediate implantation, immediate loading is limited. We analyze the case. We graft the soft tissue simultaneous. When the soft tissue is thin, means less than 2 millimeter. When the bone is thin, it means less than 1 millimeter. If you have, according to their risk profile assessment, compromised socket, we graft, and the expectation, what you said, of the patient, high expectation, high demanding cases with high smile line, yes, then we graft.
Because my just personal
Yeah,
point
please.
is that
Yeah.
the feeling, also hearing
Yeah.
lectures yesterday regarding the post-extraction site, is
Yeah.
that it's true that usually we say if the tissue is thick, connective tissue graft is not needed. But then when the patient is asking for high aesthetic, everybody's placing a connective
of
tissue
course,
graft.
you're right.
So it's
Absolutely.
more patient related than anatomical related as
Yeah,
it seems.
absolutely,
So it's
absolutely.
I think we
as
agree
curious.
all about it.
Yeah, no, but because usually we specify that it's not every time
Yeah.
needed. But if you want to have the maximum aesthetic tissue stability at the end, despite of the starting point,
Absolutely.
we are placing a connective tissue
Yeah.
graft.
Practically, that's what we do. Because we also notice, even with thick biotype, sometimes we have small recessions in immediate implantation.
Even though there is the risk that if you do too much, you get a bulky type of aspect.
Yes.
Yeah.
So,
Especially from the tuberosity.
Yes.
So
Correct.
how do you deal with that?
How do?
How do you deal with bulky?
Bulky, we have the publication from Professor Zucchelli. You have to go inside and remove it. And this is what we did in the past, and sometimes we have to deal with it. Yeah.
And still remaining on the CTG approach, there are cases where you are just solving the problem with on peri-implantitis, maybe early stage, meaning the defect is extremely small, just by cleaning and placing a connective tissue graft.
yeah.
So avoiding the grafting on the bone site,
Yeah,
basically.
if there is no really an intraosseous component and you're just having lots of inflammation with the loss of periosteum,
Yeah,
the
yeah.
connective tissue graft somehow compensates for the loss of periosteum, the destruction of periosteum.
Great, thank you.
And what's interesting is that if you see long term, not only you don't see bone loss, but you see a quote an apparent bone gain because of new mineralization.
Yeah, new tissue stability. Yeah, because this will be a topic this afternoon, discussing if it's important the thickness of the bone or the quality of the soft tissue on top to stabilize the environment. There is another question that is for Romain that is coming from the public too. If you are placing the temporary implants for those big augmentations simultaneously with the bone augmentation, or every time before going to the surgery?
Just to reduce my own stress, which is also a complication factor maybe, I like to delay it. So I know in the clinic of Professor Curry, we place the implant at the same time, sometimes the progener implant at the augmentation, but I'm just working under IV sedation, no total anesthesia. To reduce my stress, I like to make first step provisional implants, immediate loading, it is complex enough, and then I go for a second step with the bone graft.
Yeah, thank you. And you touch another point, interesting point, when we were describing the scenario of an abscess, that obviously you are immediately stressed and you would like to cry when
You're
you see
not?
something like this. No, me too. But one of the important key points in this scenario is how we are able to control our negative emotion to take a decision. Because it's extremely difficult to be rational in front of something that is pushing us outside our comfort environment. So we have really to train ourselves to control the stress and take the right decision.
It's part of the job, and it's also difficult to take the time to take a picture, for example, which is 2 seconds.
Yeah.
But sometimes you say, okay, no picture, we move forward and so on, because you're really under stress
And that
at
is
that moment.
that is bringing to a lack of documentation
Yes.
regarding the complications.
Correct.
So talking about complication and prevention, because you talked a lot also about prevention,
Yeah.
how important in your practice is patient selection? And how important to think it's important to prevent complications regarding the general status, smoker or not, perio patient or not?
It's a difficult, very difficult question, because it depends on the technique, I guess, also what you're using and what you want to achieve for results. So for sure you have to pay attention what you are getting for patients. I guess a good point is to see how motivated they are. You don't have to graft everybody, and to make maybe a small test with oral hygiene and so on, to speak for sure with smoker about the issues, the potential issues with smoker. With diabetics, I guess is a very important point, yes.
Thank you. Thank you. Then we have
Maybe just I want to know,
Yeah.
do you graft smoker patients? I think everybody in this room
Yes,
ask
I
himself.
graft smoker patient, but only with autogenous bone. I refuse to put any biomaterials by smoker. Maybe I have a small influence for my mentor in this direction. But I have a clear message, because it's also difficult. Just imagine you're a smoker and you have a missing front incisor and you have no other solution as a removable prosthesis. It's also a problem in your life, right? So who am I to tell him, you're a smoker, you don't get any implant? So that's why I tell him, I can put one implant, but you will get issues.
Okay, thank you. We still have
Yeah,
5
but
minutes.
maybe
Please,
just
go
a
ahead.
personal comment. I mean, this is a critical point, because you are, in those cases, maybe preventing worse scenario.
Yeah.
So, I mean, on the smokers, you have also to put patient in front of choice if you want to have a fixed central incisor or cigarettes. I mean,
I agree, but if you have a little bit sense and you explain everything what can happen to your patient, you tell him you can have pus, you can lose more teeth, you can lose everything in 1 year.
yeah, but you are behind that choice of
You are
during the
responsible.
treatment.
No, the issue is you are responsible for this work, and this is the problem. So this is a personal decision.
For me personally, just to have a number is that if the patient is smoking more than 5 cigarettes, for me it's not a good candidate for.
It's
for
the same
bone
for me in
augmentation.
the office. If you have a number above 5, I don't graft.
For me, it's 0.
Yeah.
So we have a lot of questions from the audience. For you, Mario, any advantage of using the sticky bone and PRF membranes in treatment of periimplantitis?
No experience with that. I can tell. I cannot say. As I mentioned, there are many protocols, there are many suggestions, there are many materials proposed. There is a long way to go. So I speak only about what I know.
Good. Maybe quick responses, if possible. A question for 3 of you. How to reduce complications for patients on biphosphonate?
I think it depends on the circumstances, because first of all, I think many medical doctors are aware of the problem, and they scare the patient about, don't go to the dentist because you are taking biphosphonates. And so education is very important, because people are confused about the fact that they may find a complication, but the highest risk is if you don't go to the dentist. So, of course, every time you take a medication, there are pros and cons. But the problem I've found oftentimes recently is to convince them that they have to come clean, do things properly under circumstances, and sometimes it happens, but not as often as people think.
Bone grafting?
Bone grafting, I do. There is a paper with oral bisphosphonates and autogenous bone augmentation, and I graft them. But there is always, and I've learned this from my mentor too, there's always a test with the extraction phase. So you can have a look how the healing is during the extraction if you have the luck to be able to extract one teeth and to see how the tissue are reacting, and also to ask why are you taking bisphosphonate, what is the purpose of the medication, and for sure with IV bisphosphonate and high doses bisphosphonate I won't, for sure.
Thank you. Uri?
We have the checklist of German Association of Implantology, like a traffic light system. When the patient is more on the green side, we do. If the patient is in the yellow or red, not. And it's always what I learned in the last 20 years, when you extract a tooth, a bone will come back by oral bisphosphonate. Also an implant will heal. But when you extract the teeth and after 3 months you see a persistent extraction socket, then no implants for this patient.
No implants?
When you extract the tooth and the bone is not coming back, you have after 3 months, still an extraction socket, means the bone remodeling in this patient is
Even
weak.
if you don't have necrosis?
It depends. You know, you need bone remodeling on your implant. You extract the teeth, you wait 4, 5, 6 months, and you look at the patient and the bone isn't there. Do you think the implant will gonna also integrate?
So it means that for these type of patient, no immediate implant placement. Otherwise,
These are
you
risky
cannot see the
patients, and
result.
also the evidence is really, Luca, I try to treat the patients like my family members. I wouldn't do it by my mother. When I extract the tooth and after 6 months there is no bone still, no.
That's important.
Maybe there are tougher guys.
So you don't graft?
Graft
No, you don't put any biomaterial in your socket?
in a bisphosphonate
In a
patient.
bisphosphonate patient?
When I see there is no remodeling, why should I put something inside?
Okay.
One last question regarding the dehiscences. Romain, do you have any experience with management of dehiscences after bone augmentation through the use of PRF?
I had in the past in the clinic of Professor Koch, just like you, I guess, but I didn't use them anymore. No, I don't have really a good experience with that one, but I don't have a bad experience with that one too.
Okay.
I prefer to try to make a soft tissue covering of the exposed area after 6 weeks, which is the period soft tissue needs to heal, instead of using PRF, but I can imagine it could be probably helpful, right?
Okay. So, gentlemen, thank you very much.
Thank
Ladies
you.
and gentlemen, thank you very much for attending this first session of the Saturday. I hope you had good spots to think about and bring back on your clinics.
Thank you.
Thank you.
Thank you.